Record. One second. Just making sure this. All right. Okay. There we go. I will go ahead and, all right, we have a few attendees on, so that's good. Welcome, everyone. We will go ahead and get started since we are at the top of the hour. Welcome to our second episode of Conversations, hosted by Growing Stronger. We are so excited to have with us Professor Ravi Savarirayan from Murdoch Children's Research Institute in Australia. Most of us refer to him as Dr. Ravi. Tonight, we will be going over some questions that have been submitted beforehand and talk about, what's going on with achondroplasia. So to start, Dr. Ravi, can you tell us a little bit, for those who don't know, what your role is at Murdoch Children's? Sure. What's a typical kind of day-to-day a patient, coming to see you would experience and things like that?
Yeah, well, hi, Chandler. It's great to be here with you. So yeah, I'm a pediatrician and clinical geneticist at the Murdoch and the Royal Children's Hospital, and basically I'm a regular doctor, and I've been there for 26 years. And basically my interest has always been looking after children and adults with various skeletal dysplasia, so problems with growth of the skeleton. And there's over 460 types of those, and we have I look after those children from pretty much from birth until they grow up. And then we follow them as adults as well. And that's looking after them from a health perspective, from an advocacy perspective. We have occupational therapists, dietitians, genetic counselors, orthopedic surgeons, neurosurgeons, and social workers in my team. And we do things from, if operations are necessary, operations, to management, to going to kindergartens, to talking to their peers about their condition, and going into the community and giving talks at schools. So it's a kind of a 360-degree kind of management clinic for with all of us in the clinic are experts in the conditions, because many people with skeletal dysplasia often find doctors and health professionals who know absolutely nothing about their condition. So it's nice for them to be able to come to see us. So that's pretty much what I do. And then obviously I do research into understanding, firstly, what causes these skeletal problems, the management, and then obviously more recently in can we give people new options for treatment that can make their health better.
So to start with our first question, I am a mother, or this is from a mother of a 7-year-old boy born with achondroplasia. We are from Sydney and regularly have follow-up appointments at the kids hospital in Westmead. My question is, how can we find more about Vesuritide, and how can my son qualify in trials? Is the drug available in Australia at all? And if yes, what do we need to do to be able to start on it?
So at the moment, the drug's not available in Australia, but I'm working with the government. We put in a proposal for approval in October, and we'll be finding out in June in Australia. I'll be going to Canberra to speak to the politicians as well. And we're hoping that sometime this year, the drug will not only be approved, but it will be reimbursed, meaning that families will be able to get it and not have to pay for it, because it's an expensive medication. Mm-hmm. And so you have to watch this space. Most importantly, the most important thing you can do is the PBAC. If you Google PBAC and Vesuritide, you can actually put in a comment, and that will be read by the regulatory authorities. And we're encouraging everyone who's interested to put in a comment on why it's important this medication should be approved for families of children with achondroplasia as an option. So, but we're hoping sometime this year, and I believe that submission process, submissions are available until the 25th of May. So I really strongly recommend that you go and do that and get everyone else who is interested to do the same.
Good. 1 second. All right. Anecdotally speaking, have you noticed in your practice that achondroplastic male patients between the ages of 12 and 15 taking Vesuritide grow at a higher velocity than approximately 1.6 extra centimeters per year, if only because those who don't have achondroplasia, so average height boys in that age group, typically have a growth spurt, more growth velocity? And it was, to my understanding, that typically achondroplasia kids do not get that pubescent growth spurt. I'm wondering if the CNP could possibly allow that age cohort to grow more at that time.
Yeah, that's a great question. And look, overall, the numbers we give you are average numbers. Some children are growing more and some children are growing less. Like any medication, it has different effects on different people with achondroplasia, because no two people with achondroplasia are the same. Okay, so obviously everyone's different. But we are hoping, because in achondroplasia, you're quite right, the pubertal growth spurt is very flat, or it doesn't happen at all. So we're waiting to see whether this medication might increase the pubertal growth spurt, not just in boys, but in girls as well. And we have to wait and see. And obviously when we have more experience with the medication in larger numbers, we'll be able to answer that question.
Okay. The next question is probably more for, our orthopedic guests, should they, when we have them. But the second part to that question was, leg bowing is an issue for some achondroplastic children, sometimes requiring corrective surgery. Do similar numbers of teenagers need corrective surgery for bowing, or is that typically needed more often in the younger years? Then they say, I would assume with more growing comes more leg bowing.
Oh, actually, so leg bowing, is quite common in achondroplasia, and maybe only 15 to 20% or less need an operation, depending on where you are. It's only really when it starts to affect other part of your walking. And sometimes it needs correction in the later part of childhood, so between 5 to 10 years, and sometimes older than that. But what we've seen is with the growth, we're actually seeing less leg bowing. In fact, none of my patients who are on Vesuritide have needed any treatment on their legs, which is actually quite positive. And obviously we're going to collect that data worldwide to see, if you're on Vesuritide, will it decrease the number of operations needed for everything, including for leg bowing. But we are certainly, and I hear this almost on a daily basis, that the parents of the children on Vesuritide say, my child's legs are getting straighter and straighter as he or she is growing more. So it appears to have the opposite effect, because the bowing itself is due to shortening of the bones, and one bone is slightly longer than the other bone. So if we're getting bone growth, it makes sense that we'd be helping that. And we certainly are seeing that. Not increased, but decreased.
So I know this was kind of in the first question, but the next question is, what is the current status in Australia? PBAC consultation closes this month, but is it going to be another year of waiting?
I hope not. I've already met with them 3 times, and I'm hoping to be fairly persuasive. It will get approved. It will get approved almost certainly in June, because the Australian government have said, if Europe and America have approved it, it's going to go through a fast track process. And so that's looking really good. What we've got to make sure is that it will be reimbursed, because we don't want families paying $400,000 per year, because that's not affordable. Because if the families want to use it, they need to use it for many years. So that's going to be political, and that's going to be me speaking to the health ministers as well as the company, but everyone else in the Australian community needs to get on and write something so that the politicians will read it.
Good. We will definitely.
At the moment, and anyone can write. So it'd be great if Chandler, if everyone listening to this webinar could get on to the Australian PBAC and Vesuritide, and you'll get to the public comments, and you can make your comments on why you think it's important or not. And so it's a really great thing to do. And then I'll be going to make sure that we can get this across the line. And I'm
Awesome.
hoping it's going to be this year. It will happen, but as many of my patients and as many of your listeners know, every year that a child's growing, it's an opportunity that they could potentially be lost. So
Yeah.
I'm understanding that many families feel that way. And of course, I keep making this point, it's not compulsory. There are many families and children who may not wish to use this medication, but I would at least like it to be an option for everyone.
Definitely. And we will definitely go to the Australian government and tell them that. All right. When will the infant trial data come out? Can you give us any preliminary information on the infant trial outcomes?
Look, there's been a very small amount released and it's been generally positive, as we expected, especially for safety. It looks like it's safe in young children. The data just got released a few days ago and it's all very secret at the moment, but I'm sitting down to write the paper very soon. And we hope that we'll have information out very soon in the next few months.
Okay.
So I'm working very closely with the medical officers at 𝘾𝙊𝙉𝙍𝙍, and that information will be out very, very soon. We just need to make sure we analyze it properly before we can announce anything. And of course, I can't say anything before the company says something as well.
Absolutely.
Because it's all fairly confidential, but there have been some preliminary things released.
Okay. How should we go about starting the process of certain growth treatments? I assume maybe if they're interested in any of the different trials going on, I think that's kind of what they were.
Sure. So I guess for for those trials going on, Australian patients can contact me, and obviously patients that are not in Australia need to contact the drug company and get connected with the investigators in their region. We can't take out of country patients, and we have many patients of our own in Australia, but most Australian families will contact myself and my team, and we have a preliminary discussion with them, and then we put them on a waiting list, and then new drug trials that come up that they might be interested in, when we get ethics approval to communicate the information to the families, that's what we do. So a lot of these trials will be starting later this year, and we're not allowed to send anything out yet because we haven't had the protocols finalized and then approved by ethics, because we can't send anything out without ethical approval. There's a very, very tight regulatory process around this, as there should be, to protect families and patients and to make sure that everything's looked at very closely before we can even send out an information sheet about a trial.
I would like to find out what the possibilities are to get Vesuritide in South Africa.
So again, with South Africa, I'm not sure what the licensing is. I know that, for instance, some of the European approvals are good in Africa, but with South Africa, I don't know. The best thing to do would be contacting 𝘾𝙊𝙉𝙍 and actually asking them about that, and that they will be able to put you in touch with the local people or let you know when it's going to be approved in South Africa. Of course, I also understand that there are families accessing Vesuritide, but that is through paying the full price for Vesuritide. But all of these things should be directed to the company in the first instance, who I don't work for. I'm completely separate to the company. I'm just the investigator who runs drug trials. The company provides us with the medication and the infrastructure to provide the trials safely.
Okay. One question, do the therapies, and I know, this is kind of in research, but it's one that gets asked a lot. Do the therapies benefit a person with achondroplasia in any other way other than just height? Does it just affect, or does it also affect leg and arm growth?
It does affect leg and arm growth, and we're getting increased function, increased abilities to self-care, increased independence. We're seeing less fatigue because arms and legs are longer, and the work of breathing and running is getting better as well. So we're seeing all of those things, and we're hoping to see less complications like leg bowing and spinal stenosis. And in the young children, we're hoping to see improvements in the base of the skull. And these are all the things that we're looking at. When we went to the regulatory bodies, though, they said height was the thing we had to use because it was the most objective measurement. But what we're also seeing is testimonials from families about improved quality of life, improved independence, all of those types of things. But height was the end point that we had to primarily meet, but we're meeting many other endpoints as well.
And that was you kind of answered the second question was, how will these therapies help when it comes to spinal stenosis?
We hope that the earlier we can give the treatment, the more the spine will grow, so that when children are in their 20s and 30s and 40s, there'll be less, but that's a long time to wait. But we're hoping, because we know that this medication not just affects the long bones, it also affects the skull and the spine, which is really important. But this is a really long-term thing. We're just starting out. It's still in the really early days, and these questions we'll find out about, and all the new medications as well, and how they're going to compare with the Vesuritide. So it's going to be an exciting few years. Why is it exciting? It's exciting because for me, it's going to give families options. And for me, as I said to families all the time, it's better that I give you all the options so you can say, no, thank you, yes, please, no, thank you, than not have any options. It's always better to have more options than no options. And you have to remember that all of these medications are not compulsory, they're optional. And our job as doctors and healthcare workers is to give families really good information so they can make the choice that's right for them.
I have one more that was previously submitted. What is the perspective for a baby with achondroplasia who starts growth treatments before the age of 2? Are they going to reach 1.5 meters proportionally when they are, I guess, by the time that they are 18 post growth?
Yeah. So again, we're going to have to wait and see. We have in Melbourne, we have the largest number of children in the 0 to 5 trial. And I have 4 patients who started treatment at 3 months old, and they're going to be treated potentially until they finish growing. So we have to wait and see, but our hope is, and we are seeing improvements in proportionality as well. So it's going to be very interesting to see how that ends up, and only time will tell. But those children are all doing well, and none of them have had to stop the medication for any safety concerns, which is really good.
Well, that's
so
awesome.
absolutely. I mean, obviously every child does differently, but we have high hopes for those children that start early, and for the families that choose to start the treatment early.
Right.
And it's going to be really interesting because in 10 years, we'll be able to compare all of the children that were on these medications and the children that weren't. And if the children that are not on the medications had a higher incidence of sleep apnea, higher incidence of needing their legs straightened, a higher incidence of needing surgeries, a higher incidence of ear infections, a higher incidence of all those things compared to the children that were on medication, well, that's a very good evidence that this medication is helping complications as well.
Good.
And just again, for all your listeners, I've just recently written an editorial in a journal called Expert Opinion in Therapeutic Targets, which I'll send to Chandler. It's just been published online, and I talk about all of the trials and all of the things we need to learn in the next few years. So that's just came out a few days ago, and it's freely available. So I will send the link to Chandler as well. But it's in a journal called Expert Opinion in Therapeutic Targets, and it was just published yesterday.
Awesome. We did just get one more question submitted live. In the future, will it be possible to combine, and this is from a parent in the US, in the future, will it be possible to combine the various therapies, Vesuritide, QEDs, Pfizer's, Synthesis, once all are FDA approved?
Potentially, and already there's work going on around that. And this is going to be a new trial, obviously, because we need to make sure that combining the therapies doesn't make side effects worse. But yeah, I'm sure combination therapy, and also if one therapy doesn't work as well, can you switch to another therapy, and which therapy is the best for which patient at which age or for which complication they're looking at. And that's really what we call personal medicine. But we're a few years away from that. But it's going to be, I think, a really exciting time where people with achondroplasia and their families will have more choices than ever before about their own health and the options. And it's really, as I say, it's going to be a discussion about giving really good information about the benefits and the risks, and then families and individuals can make their own choices.
Well, that was great. I think that was it for all of our questions. I've not seen any more questions come in through our live, but I just want to remind everyone that this was a recorded session. So we will have this up and ready, available for, your viewing. We definitely want to thank you, Dr. Ravi, for participating in this, and hope to have
It's
you.
my pleasure. I think this is great. I mean, I was just on 2 days ago, I was just on a webinar with all the patients from Norway and their parents with achondroplasia. So it's fantastic. And then before, I was on the line with Singapore, and the whole world, I think, is really interested by this. And I think it's really important for all your listeners to know that I'm not trying to push this medication. I get no profit if people take Vesuritide or not. What I'm interested in is, I'm a doctor who wants to make sure that people with achondroplasia can live healthy lives and don't need to come to the hospital. And if these medications help that, that's great. So really, it's an option, because many people write to me and say, why are you pushing these medications? We're not pushing these medications. My job is to try and help people with achondroplasia and people with skeletal dysplasia. I still go to kindergartens. I still go on radio talking about discrimination. I still go and speak to schools and speak to parents and speak to grandparents about it as well, and try and educate the community and make sure that we have accessible buildings for people with different heights and different abilities. So this is just another way of doing that. And if it means that children need less operations and have better health and don't need to come and see me, that's great.
Awesome. We did have one. Where will the journal article be published for the infant trial once that's available?
Oh, good question. You mean we're hoping it's going to be published in the highest level journal. We'll certainly be trying to send it to the New England Journal of Medicine or one of those top journals, but I got to write the paper first. But once it's out there, everyone will know. And I'm sure Chandler, I'm sure you look at it, you look at all the papers that are coming out anyway. So you'll be the first to know. And as soon as I can share some of that information, I will, and we'll probably be presenting it at conferences and things like that. But at the moment, seriously, they only just came out. The data is only being looked at as we speak. So yeah.
Well, that was it. And as Dr. Ravi, just for self-promotion for Dr. Ravi, he will actually be presenting next month virtually at the Achondroplasia Research Conference. We will send information about that as well. And to our audience members that are on, we will have a quick Q&A or questions for you to answer about tonight's webinar when you log off. But other than that, I think Dr.
Thanks
Ravi,
very much.
Thank you so much.
Thank you so much. Thank you so much. I have to go because my daughters are waiting to go home after their foot soccer match. So thanks for having me, everyone. Thanks, Chandler.
Thank you.
Okay.
Good night.
Okay. Bye.